Hello, hello, everyone, and welcome. It's so nice to see you all today. I'm Alice Melsner, and I'm the CEO of the San Bernardino County Medical Society. And this is our sixth series in our clinical education webinar series. We are very excited here at San Bernardino County Medical Society to be co-hosting this with Riverside County Medical Association, as well as IEHP, Inland Empire Health Plan, who have very generously supported this series. Today's session is Cardiovascular Wellness, Prevention, Detection, and Innovation, with a deep dive into heart disease, stroke, and cardiac health. And as you know, this is not only a tool to really help all of you as providers navigate the treatment of patients in the world of heart health, but it also will provide you with some tools and some tips to better refer patients, especially as PCPs. Sometimes it's a little bit challenging to know when and how and to whom to refer. So we have the ultimate expert here to help you with that today. We are very honored to welcome Prabhdeep Sethi, MD, MPH, FACC, interventional cardiologist with Pulse Cardiology and Dignity Health. And Dr. Sethi, we were just talking before this, Dr. Sethi has the distinction of having served as the medical staff chair at St. Bernardine's Community Hospital during the COVID time from 2020 to 2022. So he has received some accolades and some recognition for helping steer the hospital and the patients through that period. So we all appreciate that very much and know that was quite an accomplishment. Dr. Sethi also has a very impressive background as an interventional cardiology fellow at Bay State Medical Center Tufts, as well as chief medical resident at University of Arizona. So, Dr. Sethi, we are very excited to have you here today, and we appreciate your time and knowledge, and I'm going to turn it over to you.
Thank you. Thank you so much for that kind introduction. Good afternoon, everybody. Thank you for joining us today. I'm going to share my screen first. We'll talk predominantly about what are the evidence-based strategies for the prevention of cardiovascular disease. Let me just expand this. There we go. So before I dive into it, I want to set the tone for the conversation. When we talk about prevention, there are, broadly speaking, two aspects of prevention. The first one we all know as primary prevention, and that is preventing the first event, whether it's a stroke, a heart attack, congestive heart failure, aortic aneurysm, etc. And then we talk about secondary prevention, which is preventing a recurrent event. So somebody with established disease who has had a heart attack, stroke, or heart failure hospitalization, how do we keep them from having recurrent hospitalizations, recurrent events? So those are the two broad aspects of prevention. And then also we have to keep in mind, we have to talk about how do we prevent the progression of the atherosclerotic process. So it shouldn't just be about preventing a heart attack or stroke, but it should be about, how do we keep, for example, hypertension from progressing to stiff non-compliant ventricles and non-compliant vessels? How do we prevent the diabetes from progressing to nephropathy and end-stage renal disease and diffuse vasculopathy and congestive heart failure, etc.? So there are multiple components to prevention. And of course, we, the cardiologists, are your guides and your colleagues in helping to navigate this. So for this afternoon, I thought I'd start with what I feel should be our objectives. So I'd do a brief one-slide overview of the epidemiology of cardiovascular disease. I don't have to tell this to you guys. We know that it's extremely common, and heart disease, stroke, and MIs are still leading causes of morbidity and mortality in North America. Let's understand how do we risk stratify our patients and what are our primary prevention strategies. Then we'll talk about secondary prevention approaches. and then applying the current guideline recommendations in your clinical practice. And I won't be belaboring the specific guidelines because number one, there's, depending on your own sort of specialty and your country of origin, there are a lot of guidelines. There are the American College of Cardiology, the American Heart Association, the American College of Endocrinology, the European Society of Cardiology. So we, once we get into the guidelines, it's a whole talk on its own. But in general, we'll talk about the application of guideline data to your patient population. This is no surprise to you all that cardiovascular disease is a leading cause of morbidity and mortality worldwide. And when we talk about cardiovascular disease, we're not specifically just talking about, for example, heart attacks. We're talking about the entire sort of spectrum of cardiovascular disease, starting from hypertension to heart attacks, strokes, heart failure, aneurysms, peripheral vascular disease. So it is a significant burden across the planet. 17 million deaths globally per year. This is per the World Health Organization. It's a fairly significant economic and quality of life impact for your patients on an individual level. And yeah, the significant proportion is preventable. This is a, for lack of a better word, it is a man-made disease. We can prevent this from happening because it is a large part lifestyle mediated. So it's a huge impact, which means that there's the incremental benefit also of preventative strategies will be large. Once you're seeing your patients in the primary care setting, or me as a cardiologist when I'm doing a cardiovascular health screening evaluation, I kind of get a gestalt of, well, what is this patient's overall risk for cardiovascular disease? And we stratify those risks into two categories: those that are non-modifiable, so things that even if we wanted to, we can't really change. So for example, age, no matter how much we try, we can't get younger. And cardiovascular disease is a disease of aging. Gender, genetics, obviously I can't change anybody's genetics. I can't modify your DNA, at least not yet. And then family history. You can't change somebody's family history. These are your non-modifiable risk factors, and they do factor into an overall risk calculation for the individual patient. And then which are the modifiable ones? And a lot of these from the old Framingham studies. So hypertension, high blood pressure, abnormal cholesterol profile, smoking, the presence of diabetes mellitus, obesity, a sedentary lifestyle, and on, including psychosocial stress, etc. And if you look at these are all risk factors for the development of atherosclerosis. When you talk about heart attacks, acute coronary syndrome, 80% of the attributable risk comes down to abnormal lipids and smoking. So those are, if you want low-hanging fruit to prevent a heart attack, optimize your patient's lipids and get them to quit smoking. Risk factors for stroke are different than those for heart attacks, and smoking remains very, very important in that category. Diabetes, not as vital for the prevention of an ACS, but it's very, very important for the prevention of progression of vascular disease. Diabetics tend to get diffuse vascular disease. There are a higher proportion of congestive heart failure in diabetic populations. So in the entire spectrum of cardiovascular disease, each one of these is individually important. We all know about our risk assessment tools. The ones that we use now most frequently is our ASCVD risk calculator that is available online. You can get it from the ACP website, the American College of Cardiology website, the AHA website. And it asks you to put in a lot of these risk factors. It asks you to put in the patient's systolic, diastolic blood pressure, their cholesterol profile, their current smoking status, their history of hypertension, etc. And it will calculate for you a 10-year atherosclerotic risk for the patient. It does have an age limit. It does not apply to patients who are under the age of 40 or over the age of 75. It does give you an overall 10-year risk, and it puts patients into 3 risk categories. Anybody with a risk score of less than 5% is a low-risk patient. Anybody with a risk of greater than 15% is a high-risk patient, and in between are your intermediate risk. There are some limitations to the ASCVD risk calculator. It is designed and tested and applied and validated predominantly in the Caucasian population, in the North American population. It tends to overestimate risk, for example, in the Mexican American population. It tends to underestimate the risk in patients from Southeast Asia. So you have to know sort of your individual patient and then proceed accordingly. Framingham risk score, we don't apply as much anymore. It is even a more homogeneous population, and we found that it is not as applicable in our more diverse population. And then in Europe, they've developed the score 2, which has been validated in that population. Whichever risk score you utilize, you must assess it within the context of the care of your individual patient. So primary prevention, again, this is the prevention of onset of clinical cardiovascular disease in high-risk individuals. So this is a patient who has not had an event, who is living their life. They don't have strokes, heart attacks, vascular disease, and you're trying to prevent a first event, as well as I stated earlier, you're trying to prevent the progression of their cardiovascular risk factors. The bottom line here, the most important thing, the basis for all primary prevention is lifestyle modification. So you have to counsel your patient regarding a healthy lifestyle in terms of dietary discretion and a aerobic exercise regimen. Pharmacotherapy is in select cases based on your risk score. So if you assess the patient and calculate the ASCVD risk score and they are at low risk, you probably should not be putting this patient immediately on pharmacotherapy. If they're at high risk, you may want to think about pharmacotherapy. You may have a lower threshold for pharmacotherapy at an earlier stage. And the intermediate risk is a more of a goal of care discussion with the patient. But not everybody needs to be on medication as a first-line approach. Everybody should be counseled about lifestyle modification. And it should be an individual patient-centered care approach, because the studies that we have, the data that we have are population data, and you need to apply that data to the individual patient. So what are our lifestyle interventions that you should focus on? So obviously diet. You know, as I said, cardiovascular disease is very preventable, and diet is sort of one of the essential components of cardiovascular prevention. We've all heard about the Mediterranean diet, the diet high in greens and vegetables and grains and nuts, and lower in inflammatory meats. You know about the DASH diet. The National Heart, Lung, and Blood Institute has a great website about the DASH diet. The DASH diet stands for Dietary Approaches to Stop Hypertension. It's a very flexible and balanced eating plan, and it creates an overall heart-healthy eating lifestyle for the patient. And you know, as recently as 2025 by the U.S. News and World Report, it's noted to have been the best heart-healthy diet and the best diet for high blood pressure. So I sort of, for my computer savvy patients, I refer them to these websites. The American Heart Association has a great portal for patients, for the general public, for healthy eating, quote unquote. And it is granular to the level where it will give patients recipes. So it's not, you know, you don't have to go on there and purchase a meal plan or anything like that. It'll get you easy recipes that you can prepare at home. And as I said, the NHLB has a great website that talks specifically about the DASH diet. In general, you should encourage your patients to lower their saturated fats. Those are your inflammatory fats, their high glycemic index fats. Sodium should definitely be moderated in your patients with hypertension. I tell my patients that, you know, salt shakers should not be in the house. They should not be putting any added salt. Patients can spice their food with non-salt spices, but they should stay away from added salt. And then, of course, adding sugars, refined sugars are to be avoided. The American Heart Association recommends at least 150 minutes per week of moderate aerobic exercise, aerobic activity, which means, you know, 30 minutes or half an hour up to 5 days a week. That's a very, very high ask for your patient. So I am realistic. I tell them, well, if you can start with 2 or 3 days and work your way up, that would be great. And moderate aerobic activity means that they should be huffing and puffing. The heart is a muscle. It should be exercising. So they should get winded during this 30 minutes of aerobic exercise. And it can be something as simple as a brisk walk. It doesn't have to be, you don't have to go to the gym. You don't have to purchase a Peloton machine. Just go for a brisk walk, something that gets you out of breath. Weight management, we like to advise a target BMI of less than 25 kilograms per meter squared. And any modality of weight reduction is helpful. Any modality for weight reduction is helpful. And of course, I should probably put this higher up, but smoking cessation is crucial. When I have a young person come into the hospital with an acute coronary syndrome, I almost always know that they're a smoker. Smoking is attributable to about 30% of acute coronary syndrome events. And whatever we need to do to help our patients quit smoking, pharmacologic therapy, so nicotine replacement, or agents that curb the craving for cigarettes, and then behavioral support. There's lots of counseling mechanisms that you can refer your patients to. What about our pharmacologic interventions? So as I said, I'm not going to get into the guidelines and talk about targets and like what target, what statin, or what specific antihypertensive. But in general, these are the agents that help us prevent acute cardiovascular events and also retard the progression of atherosclerotic cardiovascular disease. High on this list are the so-called statins, which are the HMG-CoA reductase inhibitors. The indications for these, so how do you know that your patient should be on a statin? It's based on the measurement of the LDL cholesterol, the calculated ASCVD risk score, the presence of diabetes mellitus. So as an example, diabetic patients who have an ASCVD score of greater than or equal to 7.5% should be on a moderate intensity statin for primary prevention. Anybody who's had an event should be on a statin drug, irrespective of what their baseline LDL cholesterol is, with the aim of reducing that baseline LDL cholesterol by at least 50%. So you can use these different markers as indications for pharmacotherapy for cholesterol reduction, and then adjust and titrate your dosages and your intensity based on follow-up levels. Blood pressure control, so there have been several trials. Most recently, there was a trial called the SPRINT trial, which has demonstrated to us that tight blood pressure control with a target of less than 130/70 is actually associated with overall better outcomes. There is a slightly higher incidence of dizziness, lightheadedness in the elderly population, so you want to be a little more cautious there. But blood pressure control is imperative. And you can choose angiotensin converting enzymes, the angiotensin receptor blockers, calcium channel blockers, and of course, thiazide diuretics should be your first go-to as appropriate based on the compelling reasons for your individual patient. Antiplatelet therapy, so it's very important to remember that we no longer recommend aspirin as a first-line primary prevention therapy, especially not in women. The United States Preventative Task Force has officially, as of I think 2023, might even been a little bit earlier than that, removed that from their primary prevention guidelines. So it's not recommended for primary prevention unless you have a very high ASCVD score and a relatively low bleeding risk score. Furthermore, I would tell you that for primary prevention, I would not ask the patient to take anything more than an 81 milligram aspirin dose, because there's no incremental benefit of a full dose aspirin for primary prevention. Antiplatelet therapy is, of course, primarily used for secondary prevention after somebody's had a myocardial infarction or stroke. And then it's adjusted or de-escalated based on their risk and time from that event. Diabetes control is essential. As I said earlier, diabetes is not implicated as much in acute coronary syndrome, but it is very much a part of the progression of vascular disease. And then, just as you can get nephropathy and end up on dialysis, you can get heart failure if you have poorly controlled diabetes. So it is important to control it. Metformin is generally a first-line agent. Always consider the SGLT2 inhibitors and the GLP-1 receptor antagonists, because these have been shown to have cardiovascular benefit aimed predominantly at reduction in heart failure hospitalizations in your diabetic patients. There is some data, as we all know, for both agents, especially the SGLT2 inhibitors for non-diabetic patients as well. So this is sort of a broad stroke on pharmacologic interventions, and of course, partner with your cardiovascular colleagues for specifics. Secondary prevention. So this is aimed at patients who've had a prior event. They've either had a stroke, they've had an MI, they're having angina, they're having manifestations of peripheral arterial disease, such as having aortic aneurysms or having claudication, having low ankle brachial indexes. So they've already got established disease and they've had an event. You want to focus on preventing recurrent events and retarding the progression of disease. So obviously the therapy here is going to be more intensive. This is the patient who is going to be on antiplatelet therapy, and ideally will be on dual antiplatelet therapy with aspirin and then a second antiplatelet agent. Those are indicated post-acute coronary syndrome as well as post-stroke. They are indicated for your patients with peripheral arterial disease as well. Anybody who's had an event, stroke or MI, should be on a high-intensity statin. Your high-intensity statins, as you all know, are atorvastatin and rosuvastatin. So, you know, there is no data that 80 milligrams of simvastatin is a high-intensity statin. That still is a moderate-intensity statin, and the maximum dose for that should be 40 milligrams. So you want to have your patients with prior MI stroke to be on either rosuvastatin or atorvastatin. And then, of course, beta blockers, ACE inhibitors, ARBs, aldosterone antagonists for patients who are post-myocardial infarction, and especially if they have heart failure with reduced ejection fraction. All patients who've had an event should be referred for cardiac rehab and should be participating in a full cardiac rehab program. Cardiac rehab has been demonstrated repeatedly to improve outcomes, lead to a reduction in major adverse cardiac and cerebrovascular events. It's even been demonstrated to lead to an incremental benefit in LVEF improvement. So these are mainly guideline highlights that I've given you. The guidelines are available from the American College of Cardiology, the American Heart Association, the European Society of Cardiology, and the World Health Organization. And all of these tend to emphasize early intervention, as I said, primary prevention. So you want to screen your patients for blood pressure, get an A1C, to screen for diabetes. Patients should start having, unless they have family history, they should start at their initial lipid profile in their mid-30s, and then the subsequent intervals are based on what that profile showed. There should be aggressive risk factor control. Lifestyle modification is your baseline. That's a foundation of preventative guidelines and should be offered to and emphasized to all patients. The individual treatment and introduction of pharmacotherapy and the goal-directed therapy is based on shared decision-making with your patients. Look at the USPSTF and ADA update recommendations for the use of aspirin, statins, and SGLT2 inhibitors. As these are moving targets, and these recommendations do fluctuate. And as I just told you, the recommendation for primary prevention with aspirin has now been downgraded. So these are accessible. They're available to everybody. You can Google them. They are very interactive, and you don't have to read the entire guideline document. But I think at least looking at the executive summary is helpful to everybody. And then once you get into the areas of patients that have high risk, where their ASCVD risk is being calculated above the intermediate to high range, and worse, if they've had events, this is when you can partner with your community cardiologist to help further streamline and detail the prevention of cardiovascular disease. Just a brief word on special populations. When you have elderly patients, you do have to consider frailty and polypharmacy. So, and for cardiology, elderly, I would say, is arbitrarily defined as age greater than 75. And that's because the vast majority of our clinical trials enroll a minority of patients in that age group. So it's very difficult to generalize our trial data to the extremes of age. mainly because that subgroup within our trials is very small. So you have to consider their frailty. And these patients are on multiple medications, and you don't want them all interacting. So the therapy, so for example, maybe I don't want my 80-year-old patient to be on a high-dose, high-intensity statin because it can interact and it can also confuse symptomology. Women in general, we all know this, and this has been known since the dawn of time. They are underdiagnosed because they do present with the non-classic symptoms. There's also a tendency to underscreen women for the presence of atherosclerotic risk factors. So just have a sort of an index of suspicion that's a little bit higher to screen and evaluate your female patients. Ethnic minorities, it's not just that they're at higher risk, but that our risk calculators don't often give us an accurate reflection of their risk. So you have to really apply your risk calculator within the context of the cultural background of your patient. And then there are also disparities in access and outcomes. There are ethnic minorities that have a lot of disparities in their access to healthcare. Young adults, we all know that there's an increase in obesity and therefore diabetes prevalence in this subgroup of patients. Our ASCVD risk calculator will not give us 10-year risk for anyone under the age of 40. However, you can calculate a lifetime risk. So if you have young adults and you are wanting to calculate or wanting to get an idea for counseling purposes, what is their lifetime risk based on current demographics and laboratory evaluation, you can certainly do that. Having said that, the preventative care guidelines still recommend that you start with lifestyle modification in your young patients. You should not be jumping to pharmacotherapy in young adults. You should give them a trial of lifestyle modification. Of course, if somebody comes in with extremes of high blood pressure or their LDL cholesterol is, in the 190 or higher range, I think we're obligated to intervene pharmacologically in that subgroup of patients. Everybody else, I think, aggressive counseling and a detailed review of lifestyle modifications with a focus on dietary discretion and increasing aerobic activity. And then, more importantly, following up, looking at the effects of that, because that provides a feedback loop for your patient and empowers them to face the effect of their own lifestyle intervention on the, if they can accomplish weight reduction, if their A1C goes down, if their LDLs are reduced, if their blood pressure is improving, they get some positive reinforcement and it allows them to push the needle without going on medications. So some practical tips for my clinical colleagues. A lot of our electronic medical records have the risk assessment tools built into them. For example, I know that at St. Bernardine's, I can calculate a CHADS VAS score using their EMR. I can do an ASCVD risk calculator, and then the score is incorporated into the medical record so that you have it for yourself and for the patient every time. And then you can modify it based on the effect of your lifestyle or pharmacotherapy. Motivational interviewing. So, rather than taking an approach of blame and finger pointing, it's sort of, verbiage that motivates the patient in improving their own outcomes. As much as possible, use our allied healthcare colleagues. So refer to a dietitian, to a physical therapist, to smoking cessation counseling, to cardiac rehab programs, and then incorporate preventative cardiology into routine visits. So ambulatory medicine is very different than hospital medicine in that the vast majority of what we're doing is prevention. So our routine visits shouldn't be about just, hey, are you having any symptoms? They should really be about, well, how are we doing in the prevention of cardiovascular disease, the progression of atherosclerosis, and the prevention of events? How is your blood pressure? How are you doing with your diet? How is your plan for weight reduction? Are you getting out and exercising? How can I help you? How can I facilitate that? And of course, smoking cessation. So these are sort of, I don't have to teach you guys these things. These are sort of no-brainers for how we would prevent to decrease the burden both for the patient and for our healthcare system of this very preventable disease process. I'll give you a case study. This is sort of it's not a very complex case study, but I think this is a patient that you and I see not uncommonly. So, a 55-year-old man, he's a smoker, his blood pressure in the clinic is 150/90. And let me just stress that, when the patient is brought in from the waiting area and goes straight to the vital signs area and his or her blood pressure is checked, it's almost always higher than what it runs physiologically. So I encourage you all to recheck blood pressures when they come back elevated. Give the patient a 15-20 minute time period and then recheck it to verify. This patient's LDL cholesterol is 160 milligrams per deciliter. I don't have to tell anybody that that is elevated. Fortunately, the patient is non-diabetic. So you go through your due diligence, and I should also say that the patient is asymptomatic, quote unquote. They're not reporting any symptoms of chest discomfort, disproportionate dyspnea, or anything like that. And you calculate his ASCVD risk score, and it's 12%. So, he's in the upper level of intermediate risk now. Anything below 5% is low risk, and when you start to get above 7.5% and you're entering into the double digits, this person is in that spectrum of heading towards an event. So what is your plan? Number one, always, always, always should be a lifestyle modification discussion. So I ask my patients, tell me about your day. And patients will tell you, no, doc, I'm very active. My job is very active. I'm on my feet all day. But, when I'm in the clinic and I'm seeing patients and I'm going from room to room, how active am I really? Because I go from room 1 to room 2, and then I sit on my stool. I talk to the patient, and then I go sit in my office and do my notes. So yeah, we'd like to think that we're running around all day, but unless you're, a construction worker and carrying heavy loads and things, most of us in our day-to-day life are not getting that 150 minutes per week of aerobic exercise. So talk to them about, so are you taking a walk? Are you doing something? Do you have a stationary bicycle? Do you have something that you can do dedicated aerobic exercise? How is your diet? Tell me about your meals. Do you cook? Do you prepare your own meals, or do you buy prepackaged meals? How many times a week, or God forbid a day, are you eating out? And when you eat out, are you eating out at Subway or are you eating out at Popeyes? So these are really practical questions. You don't have to use medical terminology or anything like that. These are practical questions that you can ask your patient about, and ask them simple questions like, when you go to the grocery store, are you able to go aisle by aisle pushing the cart, or does somebody have to help you? Are you getting those? I hate those scooters that they have now in grocery stores. Are you using that? When you go to the mall and the escalator is broken, are you like confined to the lower level? Are you like, I'm not going up that escalator? So these are, more practical questions that you can ask your patient. So lifestyle modification, predominantly focusing on diet, exercise. Obviously, if he's a smoker, you're going to talk to him about smoking, and all of us know about that sort of cycle of quitting. You can't even really discuss smoking cessation modalities with a patient until they are at that ready to quit stage. If the patient tells you, doc, I have no intention of quitting, don't even talk to me, you really, but you are still obligated to address it. Hey, are you still smoking? How much are you smoking? But you're sort of trying to gently nudge them to that readiness to quit phase so that you can intervene with them. In this patient, obviously, with an ASCVD risk score of 12%, having elevated blood pressure, being a man, you probably want to initiate, I would say at this case, a moderate intensity statin. So simvastatin would be completely appropriate. I would not do pravastatin or lovastatin. Those are low intensity statins. Blood pressure management, right? So target blood pressure should be less than 130/80 in this patient. So you want to tell them that, yeah, 140/80 is not normal blood pressure. That is stage A hypertension. So this person is already well into their hypertension. So BP management, again, lifestyle management is essential. You are talking to them about salt modification. Please eliminate any salt shakers from the house. Don't be adding salt to your food after it's prepared. Try to stay away from potato chips. Try to stay away from French fries. Those are very, very high salt loads. They'll suck water in and shoot your blood pressure up. And then very, very important is smoking cessation referral. I don't think this exists anymore, but there used to be in the state of California a hotline that patients could call. It was like a very easy to remember number, like 1-800-I-QUIT or something like that. And they would get enrolled in smoking cessation classes. And for a long time, for example, Medi-Cal required patients to enroll in these before you could write for Chantix or Wellbutrin. I don't think that's the case anymore, but I do miss those referral programs. There are, depending on your healthcare plan, there are programs to refer these patients for smoking cessation. Smoking cessation is most effective when it's a multi-pronged approach. You cannot just rely on nicotine replacement alone or pharmacotherapy with Chantix or Wellbutrin alone. Behavioral modification and counseling is an integral part of smoking cessation. So that should be your start, I would say, with this patient. And then, of course, at every visit, you're going to be checking their blood pressure. Periodically, you will assess their LDL cholesterol. You will assess their smoking status. And then you'll recalculate their ASCVD risk score and adjust your counseling based on those. So in conclusion, just remember, cardiovascular disease is not as vague and ambiguous as we make it out to be. It's largely preventable. That's why dummies like me become cardiologists. It's very evidence-based, it's pragmatic, and largely preventable. Now, please note, I'm saying largely, not easily preventable, but largely preventable. It is a very active process. Prevention is not passive. It must be proactive, not reactive. In other words, don't wait for a manifestation of atherosclerotic cardiovascular disease. Be proactive in prevention. Clinicians are key to early detection and intervention. I personally take it as a failure on my part if one of my patients has a first or recurrent event. I know that's being harsh, but that's just the way that I view it. So we are very, key players in helping our patients detect the disease early and intervene early. Even at the extremes of age, in my opinion, nobody's too young or too old to practice preventative cardiology. And use your evidence-based tools and then personalize the treatment to your individual patient. So, when you calculate your ASCVD risk score, know the background of the patient and see, well, is this score completely applicable to this individual patient? Do I need to adjust it up or down when I try to initiate my pharmacotherapy? I think that's my last slide. These are some of the references that I can guide you to for preventative guidelines. The ACC/AHA very recently updated their primary prevention guidelines. I think they've eliminated, for example, aspirin. They've incorporated the ASCVD risk calculator. They've also talked about its limitations. In 2023, the European Society updated its guidelines. The United States Preventative Services Task Force has primary and secondary prevention guidelines. And then, of course, the World Health Organization. So that's why I said, if you get wrapped up in the guidelines, you're going to be, more confused than our patients are. But I would say pick one. So for me, I go with the ACC/AHA guidelines. I think they're very pragmatic. I try to understand their limitations. And then, if my patients fall within those limitations, I will then personalize the treatment. But being aware of these others are also important. But these are some references that you can, and they're fairly easy reads. And they have toolkits and things that you can put on your computer and your desktop and refer to them fairly easily. I will stop here as I am getting out of breath and open it up to any questions that you may have and any discussion.
Well, that was amazing, Dr. Sethi. Actually, it was really, really useful for both providers as well as patients. So I think we all got some value out of that. We do have several questions, which is fantastic. And Soteria is going to take us through those. Soteria, you can skip mine and hold those till the last and start with Dr. Gallegos' question.
Okay, perfect. The first question, what are your thoughts on scheduling statins daily versus nightly Should intensity statins be prescribed before bed?
That's a great question. And so first, let me give you some general guidance. A lot of the initial recommendations for statins and their administration predate our trials on high-intensity statin. And the landmark trial for high-intensity statin was the Prove It TIMI 22 trial, which compared pravastatin 40 to atorvastatin 80 in post-ACS patients and demonstrated a clear benefit. Prior to that, the majority, the biggest market share for statins was simvastatin. Simvastatin is the only statin that needs to be administered at bedtime. The rationale for that used to be because it was felt that the liver makes most of it, synthesizes the bulk of its cholesterol at nighttime, overnight, so simvastatin would have its highest effect. The other statins do not need to be administered at bedtime. They can be taken at any time. So that answers the question about the administration time. And I'm forgetting the second part of the question already. Something about moderate intensity.
It should be prescribed before bed.
And daily versus nightly, yeah.
Yeah, I would say only simvastatin needs to be prescribed before bed. Pravastatin can be prescribed at any time. And I would tell you that I don't see, unless you have a soft indication, I think that for the purposes of primary prevention, I would not go with a low intensity statin. I would go with a moderate intensity statin. And so therefore, lovastatin would have no role. I would go with simvastatin. The role of de-intensifying your statin therapy exists only in patients who are manifesting symptoms such as myalgias or myopathy. And there, you can, if you have the patient on a high dose, high intensity statin, you can reduce the dose of that high intensity statin. Then you can go to a moderate intensity statin. And by the same token, if you have somebody for primary prevention that you have on a moderate intensity statin at 40 milligrams, if they manifest symptoms, I wouldn't just switch them over to a low intensity statin. I would first reduce the dose, see if they tolerate that. Because what you want is the highest dose of the highest intensity statin as indicated for prevention guidelines. So in my mind and in my practice, the only people that get low intensity statins are the ones that have intolerance to moderate intensity statins. I hope that addresses that question.
And I apologize, I skipped the first question. It says, in regards to case studies, should we also check the serum LP? When is that indicated? If elevated, are additional therapies indicated?
That's a very good question. So let me broaden that question for you. When should I check lipoprotein or lipoprotein little a? When should I check apoprotein B? When should I check a coronary CT for calcium scoring? When are those things indicated and helpful when I am talking about primary prevention? In my opinion, you don't need to check those for secondary prevention because you should be intensifying your therapy based on the LDL cholesterol. But when those additional tests are needed are when you have patients in the what I call the gray area. So you calculate the ASCVD risk score. It is not falling in the high risk or the low risk, i.e. it's not either 4% or 15%. And the patients, for example, you get their LDL and it isn't 160, it's like 120 something. So it's not super elevated. And the patient tells you, well, I think my dad had a stent put in, but he didn't have a heart attack. He was just having symptoms. So you don't really have this sort of slam dunk for pharmacotherapy. Remember, you're doing lifestyle modification for all these patients anyway. In this kind of a scenario, checking CRP, LP little a, apoprotein B, and a calcium score will give you more tools to guide your patients. If all of those things are non-elevated, if you have a non-elevated LP little a, if your calcium score is 0, if you've got a non-elevated apoprotein B, then I think you can say, look, I just want to do lifestyle modification. I don't think we need to initiate a statin. But if your LP little a is elevated, your ApoB is elevated, or their calcium score comes back at 150, then you can say, you know what? I think it's time to augment your therapy with a statin.
Sethi, I'm just going to jump in here. There was
go ahead.
actually one more from Dr. Gallegos up above, and Dr. Gallegos had asked about this aspirin situation one more time. He said, for what patient populations should we feel comfortable prescribing ASA 81 milligram daily for primary prevention of ACS stroke?
It's a very good question. So first, let me tell you, there is no harm in an 81 milligram aspirin. So the specific of the question should be, am I benefiting? So if you, after discussion with your patient, choose to initiate 81 milligrams of aspirin, you are not harming the patient, even though the United States Preventative Task Force has eliminated it and has also stressed that in women, there is no data. In fact, there might be some negative studies. So you're not doing harm. Potentially, there's a harm for full dose aspirin because there's a higher incidence of gastritis in that patient population, but a low dose aspirin does not harm you. Where they are indicated for primary prevention, again, is in that patient population in whom your ASCVD risk score tends to be elevated. So they've never had an event, they're fairly active, but you calculate their risk score, their blood pressure is in that middle range, maybe they have a family history. Those patients where you're thinking, well, look, I want to do lifestyle, that's the patient in whom I advise low dose aspirin. Because I think that in those patients, those are not patients that have been enrolled in our trials. There are no trials that have looked at that specific subset. I think it's fair game to initiate it on those patients with the aim of helping reduce their risk. So there are two categories. One is harm, the other is help. I don't think you're harming anybody with a baby aspirin, but if you're asking, well, who am I helping? That's the patient group in whom you are helping.
Wonderful.
Yeah, I think that's all there is.
Yeah, I've got a couple then. Well, first I wanted to mention down below, Dr. Simon did contribute to this, that the California Smokers Helpline that she thinks you were referring to may have been 1-800-NO-BUTTS.
That's right. Yes, yes, yes.
Yeah, thanks, Dr. Simon.
Yes. I knew it was something catchy.
Yeah, right. Exactly. That's helpful, Dr. Simon.
I don't think it exists anymore though, because we used to get a lot of paraphernalia from them to hand out to the patients. They had these little cards you can give the patient with the number and all this information. Unfortunately, I think the state ran out of the budget, I'm presuming.
Oh, yeah, that's probably it. Yeah.
You don't get that anymore.
Okay. We'll
Allison,
check that
you
out.
asked a question about can patients calculate their own ASCVD risk score? Absolutely, they can.
Okay.
The ASCVD risk score, though, asks them to put in their systolic and diastolic blood pressure, so they would have to be able to take that, and they would have to have access to their lab results.
Okay.
But
so you know your cholesterol and all that.
Yeah, exactly. They have to have access to their total cholesterol and their LDL and HDL cholesterol. So there's no, and it's a very easy sort of, drop-down menu calculator. And the one on the ACC actually will even give them what are called next steps. So you can calculate your risk. There's a little tab you click, well, what should I do kind of thing. But that's a great question.
Okay, great. And can you remind for those of us who are nowhere near as intelligent as you on this, what is our top number on that LDL? What should we start looking at as a danger zone?
Okay, that's a very good question. That's a very difficult one to answer when we're talking about primary prevention. Okay, so let me tackle first the secondary prevention, meaning you've had an MI or a stroke. If you've had an MI or a stroke, there is no safe LDL level for baseline. So whatever your LDL was, even if it's in the quote normal range for the assay, that's too high for your physiology. And we want to reduce it by 50%. So if you came into the hospital, had an MI, and your LDL cholesterol was 110, my goal is to get it down to 55.
Oh my goodness. Okay.
So that's sort of a hard target that's well studied, demonstrated in multiple trials. When we talk about primary prevention, meaning you've never had a vascular event and your ASCVD risk score is not greater than 15%. In that patient population, there is one number to keep in mind, which is an LDL cholesterol of 190. If your LDL cholesterol is at or above 190, you must immediately get on therapy. Because
Okay.
that almost always means that you've got some form of familial hyperlipidemia. Below that, what I do is use my ASCVD. I plug it into the ASCVD risk calculator, and that guides me in terms of should I do lifestyle or pharmacotherapy. A further question is well, how much do I reduce it to? Like as I told you in secondary prevention, we want to reduce it by 50%. What about for primary prevention? And the guidelines are not as helpful, but I'll do my best in sort of summarizing them. If you've got an elevated ASCVD risk score, but you're otherwise okay, you're not a vascular patient, i.e., you don't have carotid vascular disease, you don't have a low ankle brachial index, you don't have polyvascular disease, then I would tell you that a LDL reduction of 30% is very reasonable. If you are a patient who's never had an event, but you're diabetic, you've got a carotid bruit, your ABI is less than 1, you've got multiple sort of, you're a smoker, I'm screening you for AAAs and things, that's somebody, I would tell you, 30 to 50% might be the way to go. If somebody's got polyvascular disease, so carotid vascular disease based on carotid duplex and a bruit, peripheral vascular disease, and these are all things you can screen for. ABI, I get an ankle brachial index. They've got peripheral vascular disease. They've got multiple cardiovascular risk factors, hypertension, diabetes. Those are patients you can treat like secondary prevention. So you really have to individualize it to the individual patient rather than universally applying, because then what you're going to have is a higher denominator of patients on relatively more potent and higher dose statins. And that's where all the media buzz happens about statins cause, dementia, and they cause, you to lose the lottery, whatever. So you don't want to have an inappropriately large denominator of patients on medications and then lose the true benefit.
Okay. And can exercise mitigate some of that LDL elevation?
Right. So that's great. That's a great question. So, LDL, we measure LDL because it's a point of care assay. So in other words, if I check your blood today, I can send it to the lab today and I can get an LDL result today. But what the inflammatory lipids are really your apolipoprotein B, your lipoprotein little a. Those are not point of cares. We have to send out for them. Okay. And those are markers of inflammation. So what exercise does is cause a general reduction in whole body inflammation.
Oh,
So
right.
when I recommend exercise for my patients, I don't do it with I'll check your LDL to see if you need to exercise more or less. Exercise is good for whole body, the breathing exercises that we have to do when we exercise and all that, those are all aimed at reducing the inflammation in the body. And yes, we can measure it. I can get a CRP and all that. But my answer to that would be, why? I'm not going to ask somebody, well, you need to exercise 300 minutes a week because your CRP came back at 10. We have no data for that. I don't know if that answers your question.
Yeah, that's good. That's helpful. Yeah. And Dr. Simon found that No Butts still exists as part of a program called Kick It California, and it's kickitca.org. Kickitca.org.
Perfect.
I just looked it up. Thanks again, Dr. Simon. That's really cool.
I'm glad that program still exists, and I'll start using it again. It's a great resource for patients.
Yeah,
That's
it's
great.
just part of a bigger program. It has the website, it has resources, it has all that stuff. It's got anti-vaping stuff. It's got it all.
And just so everybody knows, that program is supported by Medi-Cal.
Oh, really?
So So you don't have to have a fancy insurance to use
Oh, wow.
1-800-NO-BUTS. In fact, as I said earlier, it used to be required. Dr. Kuba has asked, is there something called too much exercise for the heart? And that's a great question. So what we know is that the benefit is accrued at 150 minutes per week. That does not mean that if you exercise more than that, you are harming your heart. Okay. The incremental benefit beyond 150 minutes a week is not as generous. Okay. So the benefit sort of plateaus. The slope of increment after the 150 milligrams of cardiovascular preventative benefit is not as much as it is at 150 minutes per week. And that's aerobic exercise of any capacity. Just remember that, for our patients above 50, there are some physical limitations to things such as running and treadmill. So we do know that treadmilling and running is a high impact exercise, and patients do have orthopedic issues when they are beyond a certain age, runners and do a lot of treadmilling, because there's Achilles tendon, plantar fasciitis. All these things can happen, and then they cause a deceleration where patients can't exercise. So I generally tell patients, if you're doing 150 minutes per week, that's perfect. If you want to do more than that, you're welcome to do it if you can fit it into your lifestyle. In my patients above the age of 50, I tell them, well, I would advise fluid exercises such as brisk walking, stationary bicycle, elliptical, rather than high impact exercises such as treadmill. Because especially if you're doing treadmill on an incline, it does get that impact translates from the heel to the hip. So that's a lot of impact on your musculoskeletal system.
What about weight training?
Weight training, there's aerobic and anaerobic exercise. Weight training falls into the isometric exercise category. We do know that with weight training or the so-called isometric exercise, there is an associated increase in heart rate. So that is exercise for the heart. One of the reasons that it is not recommended as the primary exercise modality for cardiovascular health is because you don't get that sustained heart rate elevation, and you're not able to maintain the heart rate in the elevated range. So as a practical example, if you get on a stationary bicycle and the bicycle has a heart rate detector, or you have a Fitbit, what you do is you get yourself up to your own personal target of heart rate, and then you don't escalate your exercise above that heart rate. So you don't start pedaling faster or go up on an incline. If you reach that target, you maintain that target. It's a little more difficult to do if you're doing repetitions on, the bench press or the arm curl, because when you're doing that exercise, your heart rate goes up. When you stop, especially as you exercise and your heart becomes conditioned, then there's much faster what we call heart rate recovery. So when you stop the exercise, the heart rate recovers quite quickly. So you're not able to maintain. So it's not harmful, and it should be incorporated into an exercise regimen. But isometric exercise alone, I don't think would suffice.
Okay, thank you. And Dr. Kuba did add no marathons.
Yeah, so marathons are good for whatever it is you're benefiting with your 5K, 10K. But training for marathons and marathoning in and of itself doesn't have any more incremental benefit on cardiovascular health. Now, understand that training for marathons and running marathons, as I said, is great because you have the endorphin release. Therefore, you do have whole body reduction in inflammation. So I'm sure there's a benefit, but incremental benefit on top of that 150 minutes has not been. And there's been some trial data of, is there a plateau? People keep going back and forth. So I would never discourage anybody from, most of us, myself included, are happy if we get close to that 150.
Yeah, it can be challenging. Yeah, but Well, do we have any other questions from anyone? If you'd like to just verbally ask, please feel free. Well, we have the expert on the line here.
And somebody had requested, I think it may have been one of you, had requested an email copy of this presentation. I'm happy to share it with you, Allison, if you want me to email it to you.
Thank you. We would be thrilled for that. Yeah, Dr. Brahm and Dr.
Yeah.
Wilson had asked
Nothing
about
on
that.
the slide set is proprietary, so.
Okay. We
Yeah.
really appreciate that.
Yeah,
We'll
of
send that
course.
out to everyone with the
Yeah.
recording.
Yeah.
And we will have this recording on our website as a webinar on demand, which we will then share and consider and continue to disseminate, because this was outstanding. This was really, really informative. Thank you, Dr. Sethi.
Very welcome. It's my pleasure and my privilege to have joined you.
Well,
Thank you for the
that was
invitation.
outstanding. So our next session is September 18th, and that is on mental health with Dr. Wadi Murad from Inland Psych. So we will be looking forward to that as well. But for now, we hope you'll enjoy the rest of, I guess, what you would consider your summer and a lovely Labor Day. Please feel free for the providers on the line to claim your CMA credit. Here's your code. Janice just posted that online. We will also send that out in our follow-up email. And does anyone have any last minute comments or questions? Nope. All right. Thank you again, Dr. Sethi. That was absolutely
Thank you.
amazing.
Have a great day.
Thanks everyone for joining us. We'll see you next month. Bye-bye.